everyone. Welcome to our today's session entitled Lung Transplant Surgery. We are glad to have with us Dr. Gabriel Loor, Associate Professor of Surgery, Cardiothoracic Transplant and Circulatory Support at Baylor College of Medicine. Hello, Dr. Gabriel. We are glad to have you with us.
Oh, thank you, Myrna. It's a real pleasure and an honor to be here today.
Thank you, doctor. So today we are going to shed the light on lung transplantation. We know that lung transplant offers a survival benefit to certain patients with end-stage lung diseases. However, side effects remain an important challenge for you doctors and for the patients also. So can you tell us, doctor, first, what is lung transplant?
So lung transplant basically is replacing a diseased and terminally damaged organ with a new organ. And it comes from a donor that has been declared brain dead or that has died from withdrawal of support. So when the donor is dead, then that organ that they have is still very viable, still very good quality. It's usually not the reason that they died, and it would otherwise go to waste. So we have this incredible opportunity, thanks to the generous donation of the donor and the families, to utilize that organ to reset the recipient, the person getting the lungs.
Is there any deadline to be able to take the lung from a deceased, for example, person or a brain damaged person?
Yeah, that's a great point. So clearly there is some time restriction. We don't like the organ to be without blood flow and without ventilation for too long of a period of time. Once the donor dies, we like to get the lung out usually within the hour or so that the patient has expired. The sooner the better. But once it's cooled and kept in a cool container, then we have a little bit of time. We have about maybe up to 4 or 6 hours. Sometimes some centers are trying to push that even a little longer.
Okay.
We do have some technologies now, which we can talk about later, or that help us to extend that time even longer.
Okay. So, doctor, what are the diseases or conditions that can damage the lungs to the point that a person will need a transplant?
Yeah, great question. So there are many. Advanced lung disease is the third most common killer of all diseases. It's behind only like heart disease, so it's very prevalent. And there are many different lung diseases that end up with end stage and irreversible lung disease. And that's the key, is it has to be irreversible, because if there's any chance that it can be reversible, then we really like to try to give the patient their own chance, because lung cells have, unlike the heart cells, lung cells do have the ability to divide and to replicate. And just like a skin tear or a cut, it's got a chance to come back. However, we know that when people have end-stage COPD, so chronic obstructive pulmonary disease, if they have end-stage cystic fibrosis, if they have end-stage pulmonary hypertension, if they have end-stage idiopathic pulmonary fibrosis, known as IPF, or interstitial lung disease, very similar. These kinds of diseases, at the end stage, they become irreversible. We do not have good cures for them. Recently, of course, it's been COVID, and so we've had to deal with COVID, and we've transplanted many people that had end-stage COVID, but it took us some time to figure out when it's still reversible or not. We usually give them about 6 weeks to see if it'll reverse.
Okay. So to what extent lung damage can be treated with medications before going to the transplant?
So to a decent extent. So for example, with pulmonary hypertension, there are good medicines now that can extend the period of time for years, sometimes even 4 years, 5 years, before they get to a point where the medicines don't do anything anymore. Cystic fibrosis has had a major innovation in a medicine called Trikafta that allows people to live many years now with cystic fibrosis before it's irreversibly damaged in the lungs. Idiopathic pulmonary fibrosis is still getting some new trials but there are some promising medicines that are extending the lifespan of patients with idiopathic pulmonary fibrosis. And COPD also has some interesting medicines coming down the line that are helping to extend it. But the key is that once a person is diagnosed with these kinds of ailments, the people who have the best outcomes after a transplant are the ones that are in the better shape going into the transplant. Okay. So it's a double-edged sword. We try not to let the person get so sick, but we try to catch them somewhere in between.
Okay, great. So usually lung diseases are related to heart problems. So sometimes you will face a case with a patient that will need a double transplant, a heart and a lung. Is it possible to do it at the same time, or?
You're absolutely right. That's a very good point. There are some times where either the lung disease was caused by the heart, or the lung disease adds insult to the heart because the heart can't get oxygen. So either way, the way we approach it is we try to see if the heart is also irreversibly damaged. If it is, then they need a heart and a lung transplant together. For us, technically, it's a little bit of an easier procedure because we can do them both at the same time. And it's a very reliable procedure because we don't have to worry about the patient's recovery so much from a heart standpoint because they get a new heart. Okay. So it's a very good option.
And who is eligible for a lung transplant in general? And sometimes who will be a good candidate for a heart transplant, for a lung transplant, and why sometimes people can't get a lung transplant? They are not good candidates.
That's a great question. So it comes down to the recovery. So whether the patient can recover from the surgery. So naturally, we look at age a little bit as a factor. So if a patient, let's say, for example, is older than 70 years old, it can become harder for them to undergo a surgery like the transplant. And it's not just the surgery, it's the medicines that we give them afterwards to prevent the body from rejecting the organ. So because of those two factors, we put some age. Now, we do go up until age 76, 77 if need be. But we want the patient, if they're a little older, to be in good shape, so strong. The older they can, if they're strong, then that's okay. So we look at strength. We look at to make sure they don't have any other organs that are irreversibly damaged, like the kidney or the liver. Although, if it's isolated kidney and lung, we do both organs. And we've even transplanted 3 organs, lung, liver, and kidney. But other parts, medical conditions need to be in good shape. For example, diabetes should be controlled. Heart disease should be to a minimum, unless they need a heart transplant also. So other diseases should be kept in pretty good shape. No cancer, for example, no active infections. And these sorts of things help a patient be a good candidate. And also the family support. So if the family has a good support system, then we know that will be good because the patient will have someone to rely on, somebody to help them on their transplant journey.
And do you do it for example, young people or kids, even for
yes,
children?
Absolutely. Even kids.
So at what age you can do a lung transplant for a child, for example?
You can do it even as a baby. They do it, but typically myself, I usually go down to about 13 years of age. But we have the Texas Children's Hospital that does do congenital lung transplants for patients that are born with congenital defects of the heart and the lung.
And doctor, what are the major risks of this kind of surgery?
So there are several. hopefully we keep them all to a minimum, and we try to select patients who are going to do very well afterward. But we keep an eye on many things. Number one is rejection, so that if the body recognizes that the lung is not theirs, the body starts to try to fight that as if it's an invader. So it starts fighting that lung. And we deal with that by giving them immunosuppression, medicines that keep the immune system quiet. But the consequence of that sometimes is they're a little more susceptible to pneumonia or to colds, and to things that normally you and I might not have a problem with. And so we have to be careful with that. And if they do get a pneumonia, we just treat it, and we try to be very detailed about their medications and antibiotics and things of the sort. In terms of the actual surgery, the surgery is pretty safe. It's a big procedure, but it's a very safe one.
How
So
long
the
does
chances
it
of
take?
having,
How long
so
does
it takes about 5 to 6 hours or so on average.
Okay.
It might be a little longer if it's a second-time transplant, or it might be shorter if it's only a single lung transplant. So it can vary.
Okay. And what is the percentage of success in these surgeries in general?
It's usually close to 50-50. I think it's about 50-50 between female and male.
And what is the recovery phase after that?
So after the surgery, usually after the first day or two, we get this breathing tube that they have in. We remove that. We let them start breathing on their own with the brand new lung. We get them standing and walking as soon as they possibly can.
So they are not in the ICU for a long period of time.
ICU is about 4 days, 3 to 4 days.
Okay.
And then they'll go to a step down unit where we still watch them closely, but they get to do a lot more. And then finally they go to a regular floor. So in total, we expect the patient may be in a hospital with us on average for about 2 weeks. So 2 to 3 weeks at the most on average.
And what the patient should expect after the transplant? I mean, what steps should he take, for example, to follow or after the operation?
Yeah, so they want to try to keep a mask to protect themselves from any infections. They should have a regular life. We want them up and moving and walking and playing with their kids and doing all normal things as much as possible to keep the circulatory system good. They should expect to visit with their physician at least once a month for the first 6 months, and then once a year, so that we can constantly check that the lung is working well. And there's ways to do that with X-ray or by a test called spirometry, where they breathe in and it can detect how much volume that they're breathing in. So they can expect surveillance, but we really just want them to enjoy their lives and practice deep breathing and enjoy the second chance at life. That's really what we love to do.
And are there any limitations, for example, in sports or physical activities afterwards?
So in the first 6 months, we ask them not to lift anything really heavy. So like bench pressing anything too much weight off of the chest, only because we use incisions that are around the chest to access the lungs and the heart. But there are also more minimally invasive methods that we utilize. And so if a patient's a candidate for that, then they can go back to sports even a little bit earlier than they otherwise would.
Okay. So doctor, can you tell us what happens, for example, if after the surgery, the body is rejecting the new lung?
Yeah, that's a great question. Thankfully, it doesn't happen that often early. So now it's almost unheard of that it happens within the first 30 days, for example. And that's because we have so much information about the molecular, about the genetics of the recipient and the donor. But if it does happen, we start to increase the medicines that they use to prevent rejection. So we augment that medication. And we utilize a lot of new medicines, too, that we can add to help reduce the inflammatory response. Now, if this happens at about a year after transplant, then it's not uncommon that we use these measures at that time. If it happens at 5 years after transplant, that sometimes we utilize other measures such as electrophoresis and some advanced and innovative strategies to prevent the body from forming long-term rejection. Long-term rejection is what we still battle. And we do everything that we can to prevent long-term rejection. The acute early episodes are fairly easy to treat, but the longer, more chronic rejection is harder to deal with. So we try to prevent it, and when we see it, we start treating it early.
And sometimes you need another operation or another transplant?
So sometimes you might, if the patient's lungs do reject after 3 to 5 years or afterwards, then if they're still in good shape, then they are candidates for a second transplant procedure. Absolutely. And we do have several patients actually that have been doing great up to 20 years after transplant or longer. So it can be hard to predict. Yeah, absolutely. And the second transplants are getting safer as well. So even though the average tells us that at 5 to 10 years, we have to keep a guard up about rejection, but more and more patients are surviving longer. And it's been a great advancement, but we still have a lot to learn about the anti-rejection medicines.
So the survival time after the surgery, the average survival, how many years, for example?
So if the patient, let's say they survive the first year and they don't have any acute complications in that first year, then the median time of survival can be as long as 6 to 8 years. So on average, so it could be a lot longer than that, or it could be shorter than that. So surviving the first year is very, very important, and preventing any major complications in that first year time point. We say that about 5 years after transplant, in our experience here, about 70% of patients are still alive at that time and still doing very well. That number starts to go down by the time we get to 10 years of transplant to about 50% or 30%. So it starts going down and getting lower. So we have patients that are out 20 plus years after transplant, but we have some that do die earlier. And we always, of course, remember that the challenge that we have with this advanced lung disease is that they usually present to transplant because they only have like a year left to live or less.
So this is a plus, a benefit for them, of course.
Absolutely. It gives them a chance.
Yeah. So doctor, the waiting for a donor, how long does a patient need to wait, for example, in the US? Because I know in every country it's different. But in the US, how long does, and can foreign patients, for example, come from another country and do the surgery at your hospital, for example?
Yes, absolutely. And we do that a fair amount. So patients wait an average of about 3 months, and sometimes it can be shorter, sometimes it can be a little bit longer. But the wait list, that is an important time, and that's one of the reasons why we try to have people a little earlier if possible.
So if someone from another country wants to do it at your hospital, for example, what are the procedures they should go through?
So at our hospital, we have an excellent international liaison service that works with the patient and their family to overcome any obstacles, if any, to get them here and to get them evaluated. A lot of times we do the evaluations initially by phone or by video, and then we schedule an inpatient visit as the time is appropriate.
And how long should the patient stay in the United States or at your hospital after the surgery, for example?
Ideally, we like them to stay here for up to a year afterwards so that we can check that first year is so important, that everything is going very well, because then they can go back to a normal life and enjoying things back home.
So what are the criteria a patient should look for in a hospital, or how they should choose the doctor who will do the surgery for them? What are the criteria should a patient look for?
So ideally that they've done a lot of transplants, and that they've been around doing transplants for several years as a system, and that they have a big system with a lot of intensive care units and experience in the field. The experience is very, very important.
Yeah.
Ideally, you go to a center that's doing more than 50 transplants every year, because the volume of transplants that a center does is very important in determining the quality of the outcomes. And then the surgeons, it's important to have it done by a surgeon who's had at least 500 cases, 500 transplants, if possible, because the operation is very, very important time. And even though it's safe, if the operation doesn't go perfectly, then we can't expect anything else to go perfectly. So it's a very important part of the whole journey.
So, Doctor, would you like to add anything or something that we should talk about? I skipped it maybe with my questions.
No, I think you covered so much. I will say that just as a follow-up, we're very fortunate at Baylor St. Luke's that we do have surgeons with over 500 transplants worth of experience. We're constantly doing about 70 plus per year. The wait list time here is the lowest in the region, so we benefit from that. And I think it's also helpful to know that we are involved in a lot of exciting innovations now. Number one, the outcomes are getting better and better. Number two, we have devices now that help to extend the amount of time the lung can be outside of the body. So sometimes we do transplants for the lungs outside of the body for even up to 20 hours or 22 hours with a device that keeps blood pumping through them as we bring the organ from even Hawaii over to Houston. So that's been really helpful. And lastly, there's even innovations now if a patient's very sick before transplant, that we have very small portable units that essentially replace the lung, called portable ECMO. And they can actually be in our units, safely monitored and safely watched with this until it's time for them to get a transplant. So there's a lot of exciting innovation going on in the field of advanced lung disease. A lot of great medicines, outcomes are getting better, and innovations are getting really good. The important thing is if someone feels that they're getting to this point where they have advanced lung disease, they need to talk to their physician. They need to insist that they get referred to a center that has some experience with transplantation if possible.
So which organ is the most needed, for example? What kind of transplant you do, lung, heart, or other kidney? What is the number one organ?
So it's hard to say which is number one because they're all needed, but heart and lung are, obviously critically important, but so is liver and so is kidney. Those are the most common ones that are done. Thankfully, with kidney, we have dialysis, so patients can still be surviving without a kidney. But for lung transplant and heart transplant, those are really vital and immediately life-threatening. I personally do both, so it's nice to be involved with different types of diseases.
Thank you, Doctor, for your time, and thank you for the information you gave us today. And hopefully we'll have another interview about heart transplants mainly.
Absolutely. Anytime. Myrna, thank you so much for having me.
Thank you.